we stopped at the memory, and this was the cellular mechanism of memory formation. There are actually some anatomical changes that occur when we create a memory for something, and these changes are increased neurotransmitter in certain areas, facilitation of synapse, and additional synaptic connections. These are the three changes that actually happen when we create a memory. And what were the organs that consolidate memory and move it from short term to long term? Does anybody remember? What are the organs or what are the parts of the brain that consolidate memory, push it from short term to long term? What are these organs? It will be stored in the cortex, but what push it to the cortex? This is where it's stored, cell association area, which is the cortex. And amygdaloid, hippocampus, and amygdaloid. Plus or minus nucleus basalis. Nucleus basalis is not well established, but amygdaloid and hippocampus, those two parts are what help you to consolidate your memory from short term to long term. And these are the anatomical changes one more time. Neurotransmitter increase in that area. Synapses are facilitated, and more synapses, additional synapses. Okay? So this all occur at certain synapse. Neurotransmitter increase, facilitation of the synapse, formation of additional synapse. These are the changes, the anatomical and chemical changes that occur in order to create a memory. So increased neurotransmitter, facilitation, and formation of additional connection, synaptic connection. Now, what's the memory engram? The memory engram means a single circuit that responds to single memory. So when you memorize something, for each piece of information, there is a circuit, one circuit that is created. And to create this circuit, you need repetition. And I talked about that last time when I said, when you hear something, when you read it for the first time, it goes only to the short-term memory, which you can recall immediately, but just give it a couple of days, it's gone. So you need to consolidate the memory and push it from short-term to long-term, specifically the secondary. The tertiary is lifelong memory, but I'm talking about the secondary now, which is what you're actually using when you study something. You start in the short-term memory when you study one time. When you study it for the second time, you push it from the short-term to the secondary long-term. Okay? And in order to do that, you need to repeat. Repetition help you to create the long-term memory. What help you to do that? Amygdaloid and hippocampus. Now you push it inside your secondary long-term memory. What happened within your cortex, within the association area? There are anatomical and chemical changes that actually occur. The neurotransmitter increase. Facilitation in the synapse. Formation of additional synapse. All of this together will add up to make something called circuit. So I'm studying that I have 12 cranial nerves, for example. I have 12 cranial nerves. That's what I'm studying right now. So at the synapse, neurotransmitter will increase. You'll make more synapses. Okay, and this together, for this single piece of memory, is called engram. Engram. So how many engrams you have? Thousands, depending on the amount of information that you memorize, long term. Each one of those is called engram. And every time you memorize something, it's another engram. You have a lot of these, thousands of engrams. And the formation of these engrams and being permanent or not depend on how many times did you repeat. And that's why you're supposed to study, repeat. Now you have a long term. And if you repeat it one more time, you're making this circuit or engram stronger. So it stay more. It takes about 1 hour to do the conversion, and repetition is crucial. It's very important to repeat. The more you repeat, the more it gets stuck and gets stronger engram. And there are other things that are associated with the conversion. It's not only the repeat. The nature, intensity, and frequency. Nature, is that something that's boring? Is that something that you don't care much about? Or this is something that attracted your attention, and the nature is important to you? This is something that you really wanted to know, or something that's the nature is not very important? Intensity, if there is something intense, not necessarily learning, like if a problem happened to you that's very intense, you don't forget it, right? When you have a problem or an accident or something, it gets stuck right away. It moves immediately from short term to long term, even if you didn't repeat it, because the intensity was too strong, right? Frequency, how many times did you hear it? When you repeat, or I repeat, it get converted more. So strong, repeated, and exceedingly pleasant or unpleasant, like a happy surprise that happened to you. Okay, you will not forget it. It will stay. A very bad situation or something, stimulus or a memory that was bad. You have an accident, you have a problem, you have a fight with somebody, you don't forget it. So is it strong? Did you repeat it? And the nature. Is it good? Is it too good? Is it too bad? Something neutral is the least to remember. What's neutral? Like what we're doing now. Is it too pleasant to learn about the central nervous system? Not much. Is it too bad? Is it something horrible? Not that much. So it's not pleasant or unpleasant. It's something neutral. And this is something, the nature is neutral. This is something that you have to actively repeat it in order to form the circuit for it. There are some drugs that actually facilitate the process also. It's not only about repeating and nature and so on. There are also something that, like the caffeine and nicotine, they enhance the memory consolidation. Yes, it is effective, really. So when you say, I need some coffee to help me memorize, yes, it's not magic. It's not like increase that the ways that some people think, but it does have some effect. Nicotine, cigarettes, does it help? Yes. I'm not encouraging anybody to smoke, of course, but it is scientifically true that the nicotine helps just a little bit. It's not that much, but it helps the consolidation through facilitation. It facilitates the synapse. There are some receptors that are called the NMDA receptors, and these help in the consolidation of memory. Now, state of consciousness. You can be completely awake. You can be relaxing. You can go to sleep, just the first degree, and then you can go to deep sleep. Deep sleep is called the slow wave sleep. Why did you call it this name? Because if you do an EEG and recorded your brain activity in the shape of waves, did anybody see an EEG before? Did you see an EEG, how it looks like? So the EEG will give you an idea about how your brain activities while you're sleeping. So if in the case of deep sleep, if you are sleeping deeply and these electrodes are connected to your head, it will show a graph that tells you, and the waves will look like this. So these are slow, large waves, delta waves. So delta waves, which are slow waves, it shows deep sleeping. And during that time, the cortex, the activity of the cortex drops, so you don't think about anything, you're deeply sleeping. And the other functions will decline. Heart rate, blood pressure goes down, respiratory rate. This is when you breathe really slow, your heart rate slow. Everything basically relax. Heart rate, blood pressure, respiratory rate, and energy decrease. This is what happened in deep sleep. The other stage of sleep, I think we all heard about REM sleep. REM, rapid eye movement. Your eyes moves like this while you're in the middle of sleep. It goes right, left like this. Okay, fast movement, rapid movement of the eye. Stay for some time and then disappear. And when we sleep, we alternate between REM and deep sleep. And REM is where the dreaming, the main part of the dreaming. So REM, dream, just to remember it, this is how I remember it. REM, DREM or dream, REM, dream. And the most significant thing about this stage is the muscle tone drops dramatically. The muscle tone. So you'll completely relax. Your muscles relax. Do you mean that during deep sleep, the other stage, your muscles are not relaxed? Not as much. So you do have a good tone. So if I hold your hand like this, while you're in deep sleep, it will go like this. Okay, while in REM, the muscle tone completely almost lost. The muscle tone goes down. And what's the rationale behind that? Because you need to do two things. Why you're sleeping in the first place? You're sleeping for two reasons. Number one, to clear your brain, right? From stress and from everything. You don't want to, you want to give some rest to your brain. And at the same time, you need to relax your body, right? You're relaxing your body, you're relaxing your brain, both of them. You alternate between those two. During deep sleep, you relax your brain. Not much about your muscles. And then you alternate, and during REM, you completely relax your muscles. So when you wake up, if you have some good sleep, your muscles will be ready to work, your brain will be ready to work, right? Because you give yourself both of them. And if one of those two is missing, this is a problem. Because you need to give some rest and relax both of them. Okay? So during REM, the muscle tone dramatically drop. During deep sleep, the brain activity drops, plus heart rate and respiratory rate. Now the problem is, because during REM specifically, there is something called sleep apnea. Are we familiar with this term? What's apnea means? Not breathing. Yes, you stop breathing for some time. And the apnea, there are two types of apnea. There is central apnea and there is obstructive apnea, sleep apnea. Central apnea is a problem that I'm not going to talk about. It's the brain don't give a signal for your respiratory system to work for some time. Like you're breathing, a signal go to the respiratory system, breathe. Another signal, breathe. Another signal, breathe. One time, no signal goes, so you don't breathe, and then a signal come back again. This is called the central sleep apnea, and this is rare. The one that I'm talking about now is the obstructive sleep apnea. So when you breathe, you're sleeping, you breathe, right, through your nose, you're supposed to. Some people, sometimes you breathe through your mouth, that's not good. But let's talk about the normal, you breathe through your nose, nasopharynx, right? And the oropharynx, laryngopharynx, larynx, and so on. This is the tube through which you breathe, right? And some people have the muscles inside, the tone is low tone. So it's kind of lax, not rigid enough. Or some other people have their respiratory passageway narrower. Okay? So it can be narrower. Sometimes it's not narrow, but it is too relaxed, it's too soft, not as rigid. So specifically now, it's even worse when you go to REM and your muscle tone is lost. So automatically, even if you're not sleeping, it's not like this, it's relaxing. So once you fall asleep, specifically during REM, this is your respiratory passageway. This is where you tube that you do the respiration. So normally it is like this for any reason. And when you go to REM sleep, your muscle tone is completely almost lost, so it blocks. So you go like during sleeping, you're sleeping, deep sleep, and you go like this, you open it, and when you open it, it's your brain giving you a stimulus. And the stimulus came because when you do this, you're breathing, relaxing, especially you go to REM, block, completely closed, apnea, you stop breathing because of obstruction, oxygen in the body goes down, the brain is awake, and it will give a signal to the respiratory system, breathe. So you start to breathe. You get the tone again, and then you sleep, relax again, until your throat closes again, and so on. So this is the sleep apnea, and it's more evident during REM sleep because of the drop in the muscle tone. So you normally you alternate between deep sleep and REM. And REM stays for about 5 minutes to start, and then it goes longer. So you go like this. Okay, you're awake. Okay, and you relax. And let's say this is a deep sleep. You go to deep sleep, right? You stay for some time and get some REM. 5 minutes, let's say. And then deep sleep, more. Deep sleep, more. Okay? So let's say this is 5 minutes, this is 8 minutes, 15 minutes, 20 minutes. So the length of REM increase as you sleep. So the last REM before you wake up is the longest one, but you stay long time in the deep. Okay, so let's say you take 2 hours, and then you get 5 minutes of REM. Another hour, and then you get 10 minutes REM. 2 hours, 15 minutes. Another 2 hours, 20 minutes, and then you wake up. Okay, did you get this? So it increases the length as we go. The longest one is about 20 minutes, and this will be the last one. So again, you sleep because you need to relax your body. You need to replenish your resources. During sleeping, you increase your protein synthesis in the neurons. Your neurons make protein as you're sleeping. Okay, and we're supposed to sleep the average time. What's the average time for you? 8 hours, approximately, yes. And is it more in children, or in adults, or in elderly? Children, and goes down, right? And during in elderly, it can be like 6 hours or something. Okay. And they say 25% of the population have some sleep disorders. The most important one is sleep apnea, followed by insomnia. And insomnia means you either don't fall asleep, or you do, and you wake up really early. Like you go to bed 11 and you're fine. 1 or 2 a.m. you wake up, 3 a.m. you wake up, and you don't fall asleep. So both of them are called insomnia. These are the different waves that we can see in EEG. This is a very rapid. If you are awake, you see this. During REM, it looks like this. During deep sleep, it looks like this. And this is the REM deep sleep, REM, deep sleep, REM. So REM is obviously increasing as you go. The one organ inside your brain that help you to stay awake is called the reticular activating system. And remember that. This is what help you to stay awake. Reticular activating system, or RAS, R-A-S. So this is when you wake up in the morning. RAS wake you up. Okay? And what activates RAS? It's either you got enough sleep, so RAS, or the reticular activating system, will wake you up automatically, or something activated the reticular activating center. Like what? Like you see sudden flash of light, or sudden noise, right? When you hear a noise, you wake up, right? And you didn't sleep well yet. You wanted to sleep, actually. Why waked you up? Activation of RAS. So if it is activated with something that's excessive, or you slept well, you got your sleep, and the RAS is programmed that when you get a good sleep, it will automatically start in the morning. Okay? But you can start earlier, prematurely, if something happened, like sensory or motor, somebody touch you, wake up. So this was going to stimulate or activate the reticular activating centers, or something sensory, or other sensory. You hear something loud, or you see flashes of light or something like that. And so you stimulate the reticular activating centers, which stimulate the cortex, and you wake up. Reticular activating system, or RAS, RAS. And RAS is located in the brainstem, from the medulla to the mesencephalon. This is the location. When the RAS is inactive, your cortex is inactive too. When you stimulate RAS, it will stimulate the cortex. So what do you think? Just think about it. This is all what we're talking about so far is normal, right? You're sleeping, reticular activating system go down or inactive, your cortex is inactive. You wake up in the morning, RAS is active, cortex is active, and you're awake, right? Or your RAS is inactive, your cortex is inactive, something happened to wake you up, stimulation, and the cortex is active for some time, and then you go back to sleep. What if the reticular activating system is damaged? What happened?
You start sleeping.
You start? What wake you up? The RAS. You don't have it.
You stop waking up.
Which is coma. This is how we get into coma, okay? Reticular activating system, something happened to it. Whether chemical change or accident or something happened to it, so you don't activate your cortex anymore, and you fall into coma. So here is the location of reticular formation. Reticular formation is part of the reticular activating system. Reticular formation, reticular activating system in the brainstem. Okay, some disturbances that can occur to the brain function, something like Huntington disease. Huntington disease is destruction of acetylcholine secreting and GABA secreting neurons in the basal ganglia. A problem happened somehow that the neurons that used to secrete acetylcholine, they are destructed or deteriorated for some reason. So you don't have enough acetylcholine. This is a problem with Huntington disease. So what's the Huntington disease again? The neurons, specifically acetylcholine, it's more important than GABA. It's both of them. The neurons that secrete those two chemicals that are located in the basal nuclei got destructed somehow. So you don't make enough acetylcholine or GABA anymore, okay? What was acetylcholine and GABA doing? Specifically acetylcholine. It was regulating your movement. If you lose it, you don't have enough acetylcholine, you don't regulate your movement, so you start to do uncontrolled movements or difficultly to control movements. So basically with Huntington disease, and I saw patients like those, they do some random movements like this, uncontrolled movement. Can you stop? Can you stand still and don't do any movement? Okay. Do like this. He is trying to actually control it, but he doesn't have enough acetylcholine to control it. Okay? So what do you think will be the treatment for that? Give him acetylcholine. Yes. It doesn't mean it will be cured. Okay? It's improved. So Huntington disease, destruction of acetylcholine and GABA in the basal nuclei. Okay? The nuclei start and the frontal lobe also start to degenerate, difficulty controlling movements or uncontrolled movements. The problem is the intellectual ability itself, so it's not just these movements, this is in the beginning. Later on, after years goes by, the intellectual abilities, the way of thinking and decision making and memory start to deteriorate. LSD. Did you hear about this? Of course. One of the hallucinogenic drugs, this is something that's street drugs. And what it does is it causes hallucination, one of the hallucinating drugs, and it works by activating serotonin receptors. Serotonin. And if there is one thing that you need to remember about serotonin, two things. Number one, it helps you to feel high or you feel good and help your sleep. Okay? And this is exactly what happens if you are depressed. What's a depression? Serotonin. You don't have enough serotonin. Okay? So serotonin is a chemical compound that helps you sleep and you feel good. If you take something that stimulates serotonin, you don't feel good. You feel too good or hallucination. It's not really good, but I mean you feel high or hallucinating. So what's LSD doing? Hallucination through activation of serotonin. So if you have a problem with serotonin, what do you have? If you have a problem with serotonin, you don't have enough serotonin, you feel good or bad? Bad, which is called depression and anxiety. And depression and anxiety are very related, and most of the time they actually go together. A lot of people having depression and anxiety. Most of the time it goes together. So the problem here is depression and anxiety, you don't have enough serotonin. How to solve this problem? If you don't have enough serotonin, serotonin give you, but there is nothing that's called give you serotonin. It can't give you serotonin. There is another way to solve it. Okay, if somebody is using one of these SSRIs, if you're familiar with these medications, the SSRIs, there's Zoloft and Prozac. If you heard about these medications, these are, it is going to increase serotonin somehow, and here's what's happening. Okay. This is the presynapse, and this is the postsynapse, let's say, and you're secreting serotonin. Okay. Let's say just random examples. You're secreting 5 units of serotonin, just any random example, okay? And you feel okay, you're fine. Something happened, trauma, a problem, something happened, and you don't secrete enough. You feel bad, okay? There is nothing I give you serotonin. You don't get serotonin. How to solve it? Here is how they solve it. Serotonin goes to the postsynapse, do the action, and you feel good. This is normal. You don't have enough. You feel bad. You're depressed. How to solve it? Here is how to solve it. After the serotonin do the job, it will go back and you retake it. Okay? How about if I block this? You don't retake it. So you secreted 3, you do the job. As they are going back to reuptake them, you stop it. And you start to secrete more. Those are still here, right? You do the job, now you feel good. When you try to reabsorb, I block it, block part of it. You get more, okay? So this is selective serotonin reuptake inhibitor, SSRI. What do you mean by that? Reuptake inhibitor. When you try to reuptake it means you take it back, you uptake it back, we block it with one of these medications. So this is Prozac or Zoloft or any one of these medications. It blocks the reabsorption process. So make serotonin more available. You feel better. This is how it works. Okay? And why did you call it selective serotonin? Because the older generation probably didn't hear about this, but there was another generation that blocked the reuptake of other things. It's not selective. This is the old generation, and it was bad because even though it blocked the reuptake of serotonin and you feel good, but it also blocked the reuptake of adrenaline, so you feel like sympathetic, okay, you feel agitated, which is bad. It blocked dopamine, okay, would have some bad effects. So this was the generation that they used for so many years until they came up to what was the problem when I give you a medication to depression. You stop the reuptake. Yes, the reuptake of what? Of many transmitters. Do you want these many transmitters? No, I want serotonin. And the other things will just happen automatically. So how about we create something that can actually selectively block serotonin only and have nothing to do with anything else, and this is the safest medication for depression and anxiety right now. Just block the reuptake, you have more serotonin available, and if you have more serotonin available, you feel good. And the way it works, there is nothing until now, nothing to measure it. They don't put something like on your brain, you need 75 milligrams. It doesn't go like this. They usually start with the low dose, like 25 or something, 25 milligram. 50 milligram, how do you feel? Come back after 2-3 weeks. Do you feel better? Yes, I'm still depressed or anxious, too anxious. I have panic attacks or something. So, okay, so 50 is not good. How about 75? Let's try 75. Come back in a month. How do you feel now? Yeah, I feel okay. That's it. So you actually need 75. Still not 50. So it's just, they do it by just trials. They try, and the minimum that do the job is your dose. So something like fluoxetine, Prozac, selective serotonin reuptake inhibitors, Celexa, Lovox, Paxil, Zoloft, Prozac, and so on, any one of these will do the job, blocking the reuptake of serotonin. Parkinson's disease is another problem that is related to dopamine. So if I ask you, Huntington, which neurotransmitter is affected? Acetylcholine and GABA, but more acetylcholine. How about the depression and anxiety? Serotonin. Parkinson's disease, dopamine. You have a problem with dopamine. Okay, and dopamine is secreted from something called substantia nigra. And what's nigra means? Black. Substantia nigra is a black spot in the brain that produces dopamine. There is a problem somehow, and you don't have enough dopamine, and you start to have motor problems. And motor problems is basically you don't produce enough movements, okay, which is the opposite. the opposite of Huntington disease. Did you notice this? Huntington disease, you produce uncontrolled movements, so you increase your movements. Parkinson is the opposite. You don't produce dopamine, so your movements will be decreased. Okay, and it affects both the motor, the movement, and the behavior itself. And sometimes they call the Parkinson disease the mask face disease. So you talk to those patients, they don't smile, they don't do anything, like this, mask face. You say something pleasant, doesn't matter. Something bad, it doesn't matter. It's not like they don't feel it, they cannot express it. They have a lack of control over their facial muscles, the muscles of the facial expression. So this is really bad because they actually feel if it is good or bad, they cannot express it. So they feel like they get like the mask face because they don't have enough dopamine. So how to solve this problem? Give them dopamine somehow. And what helped to produce the dopamine? Something like amphetamines, speed. And amphetamines is something that's one of the drugs that's been abused. Okay, and did anybody use the amphetamine before? Do you know the effect? How do you feel if you get amphetamines? You feel like more. It's not something good, the way I do it. Okay, but it's not that good. You feel active, no much need to sleep. You concentrate, so you think it is something good, but it has bad effects. It stimulates dopamine, so you produce more movements and you're more active. Okay, but in this case, they gave it to the patients because you don't have it, not because you wanted to increase it. You're not supposed to increase it. Okay, so Parkinson's disease, dopamine, unusual sensation, abnormal movements, and inappropriate behavior. What happened in aging? Everything deteriorates. So if you think about it, atrophy of the cerebral cortex, for example, what happened to the gyri and what happened to the sulci? Which one increase and which one decrease? If you're shrinking in general. The gyrus, if the gyrus increase, this is the opposite. If you shrink, the gyrus decrease. And what happened to the sulcus? What's the difference between sulcus and gyrus? I think you guys are familiar with this. If it is like this, yes, gyrus, sulcus, gyrus, sulcus, gyrus, sulcus. If this decrease, what automatically happen to the sulcus? Gets bigger. Yeah, this will get flat, mean it's small. But this gets bigger. Okay? Deeper and bigger. This is what happens if you do one of the imaging studies. You will see that the gyri start to decrease, and the sulci automatically, when you decrease the elevation, the depression will increase anyway. So you decrease the elevation, you increase the depressions on the expense of the elevations. Okay. So the size decrease, the weight decrease, the volume decrease, the amount of neurons decrease, the memory decrease, concentration decrease, everything decrease. The gyri will become narrow, the sulci will become wide, the subarachnoid space become larger. Any space or depression become larger. Any elevation or brain tissue becomes smaller, shrinking basically. If you put this all together, shrinking, losing neurons. Number of neurons shrinking. If you put all of these together, just remember shrinking. The brain shrink. So if you think about it, the brain shrink, that will give you an idea about all the anatomical changes. Blood flow, of course, decrease because of arteriosclerosis, atherosclerosis, and arteriosclerosis. It's not really fatty deposition. I mean, this is misleading a little bit, but anyway, atherosclerosis, arteriosclerosis, when the lumen become narrower. The lumen of the arteries become narrow. So not enough blood supply go to the brain. And the problem that can happen is stroke. What's the stroke? It's a cerebrovascular accident, CVA. If you think about this word, cerebrovascular accident. It's an accident in the cerebrum because of something in the vessels. Just think about it this way, right? Cerebro means cerebrum or brain, vascular, blood vessels, accident. An accident that happened in the blood vessels affecting the brain, okay? What can happen to the blood vessels affecting the brain? Either blocked or ruptured. Something that interfere with the blood supply to the brain, basically. And of course, what happened to the brain tissue? If the brain tissues didn't receive enough blood, they will, or if it's completely stopped, die, okay? And there is a difference between ischemia and infarction. What's the difference? Ischemia and infarction. Ischemia. What's isch means? Less. Emia? Blood. This is just translation, by the way. Isch, less. Emia, blood. Ischemia, less blood. This artery used to give you a liter per hour. When you narrow the lumen, it will give you half liter. Ischemia, less blood, right? Narrower. This is called ischemia. If you block it completely, you shut it off, no blood at all go to certain part of the brain, it dies. This is infarction. Okay? And this is the CVA, cerebrovascular accident. So this is an actual damage, death, not just ischemia, not just less blood, shuts off completely. So this part will die, damage.
Don't infarctions leave like a career?
A what?
Like a career, like one of the dead tissue?
It shrink, it become fibrous, it decrease in size, okay? And the action will depend on which part, and it's random, by the way. So if you hear somebody like relative, okay, grandpa, somebody, he has stroke, and what happened to him after that? He couldn't move his right upper limb. Somebody else, he couldn't move his left. Somebody else, the upper limb and lower limb. Somebody else, he got blind, right? We hear about all of this, right? What's the difference? The difference is something come and block the artery, and this is completely random. You know, it's just moving in the circulation, and it will block something. Which something? You don't know. Anything. Just if it goes to the blood supply that goes to the cerebral cortex, for example, for the occipital lobe, what will happen? It will be occluded. And what was the function of the occipital lobe? What's the area there? Auditory? Vision. So what happened to those people if a thrombus came and blocked the artery that goes to the occipital lobe? They get blind. They get blind.
Does that happen immediately or just like as time passes?
It depends on if it shuts off completely or it decreases until it shuts off. If it shuts off completely, like a thrombus came and just block it, blind, right away. Okay? If it come and block it and there is still blood leaking until it completely shuts off, it takes some time. But the point I'm trying to make here is when the blood vessel is completely blocked, this part will die and lose the function. What if CVA affected the temporal lobe? What is the problem? Hearing? Yes. You lose your hearing. What if it affected the primary motor area? Which is? What is it? Paralysis, yes. You can't move. How do you produce the movement? Isn't it in your primary motor area? Right? So if the blood vessel shuts off at the area that control the hand, for example, paralysis of the hand. What if it gets a larger part of the upper limb. You lose the upper limb, paralysis of the upper limb, right? And so on. So depending on which area is affected, it will lose the function, and depending on which function is it. Synaptic organization, everything decrease. Dendritis decrease, spines decrease, connections decrease, synapses lost, neurotransmitter production decrease. There's something called lipofuscin and neurofibrillary tangles. These are pigments and abnormal compounds, chemical compounds that start to accumulate in elderly. And those two are, they found out that people having Alzheimer's, and Alzheimer's usually occur to very old people, right? And because of this accumulate, one of these two, lipofuscin or neurofibrillary tangles, when they accumulate in the cortex, they start to lose memory. And Alzheimer's is all about memory, right? Ronald Reagan, what happened to him? He at a certain time, he didn't recognize his own family, right? His kids, his granddaughter, and so what happened here is the memory is lost. Why? Because of accumulation of these two. Something else that's called plaques. Okay, this is a protein that deposit. So these are the anatomical changes that happen with aging process. Plaques and tangles, amyloid protein, amyloid B protein, if it started to accumulate, the memory will be affected. The memory consolidation is more difficult, and that's why they always say the older you are, the harder to learn, right? Because when you're younger, everything is working fine, specifically the amygdaloid and the hippocampus. So when you study something, you repeat it once or twice, it goes to the long-term memory. When you get older, these organs will become less functional, less effective, so it takes them 3, 4, 5 times in order to consolidate the memory. So my memory consolidation is less efficient, harder. Secondary memory are harder to access. The one thing that's usually is not affected by any of what we're talking about now is the tertiary memory. Okay, tertiary memory. Like you talk to some older people that having Alzheimer's or having memory loss or something. What did you eat yesterday? I don't remember. Who is this? I don't remember. Can you tell me something about yourself? Yes, 60 years ago, I got married and I had this problem. 35 years ago, I had an accident. This is the tertiary memory, right? Nothing happened to it. It's in the back. So the new memory or the memory consolidation is the one that's actually affected. They also get some sensory problems, hearing decrease, balance disrupted, vision decrease, taste decrease. Just choose decline in everything, all functions, motor controls, everything. Incapacitation is a term that means a problem or changes that actually interfere with their abilities. So if the changes did not interfere with the ability, that's something. But if it interfered with the abilities, it's too progressive, that's incapacitation. Senility in general, or senile dementia. What's dementia means?
You free Alzheimer's?
Alzheimer's is one of the forms of dementia, which is basically loss of memory. This is the most important thing, not the only thing, but the most prominent thing. So if you talk about dementia, meaning memory loss, this is the most important thing, memory loss. Dementia, memory loss. Senile dementia is the most common one. So people become senile and they start just normal aging process. It's a problem, but it's very common with aging. They start to lose memory, and specifically the antegrade amnesia, meaning they cannot store newer memories. And of course they get some emotional disturbances because of, most of it is related to the changes that happen in elderly, and also related to losing of memory. Alzheimer's is the most common form of senile dementia. Alzheimer's disease, most common form of senile dementia. Progressive loss of memory. Memory. It's all about memory. Any one of the dementias is memory. You lose memory. And the anatomical changes is, I just mentioned that, plaques and neurofibrillary tangles form and deposit in the cortex. Are we following? Alzheimer's, the most common form of senile dementia. What's senile dementia? Loss of memory in older age. Why? Plaques and neurofibrillary tangles deposit in the cortex. They form and deposit in the cortex. Okay? And specifically the nucleus basalis will be damaged. It might be damaged. But what's the most important anatomical change? Deposits in the form of plaques, neurofibrillary tangles, form and deposit in the cortex. Some other problems with the nervous system include infections, something that like polio and rabies. What happened in polio? Is it infection, viral or bacteria? It's viral. And what does it affect? It distracts the anterior horn. What's the anterior horn doing? Is it sensory or motor? Anterior horn, is it sensory or motor? It's motor. Did you forget this? The dorsal and the ventral. Do you remember the H-shaped gray matter in the spinal cord? Yeah, what's the posterior or dorsal? Sensory or motor? Dorsal? Sensory, and the ventral or anterior? Motor. So when it's destroyed, you lose the motor function, paralysis. Okay? Congenital disorders, something like spina bifida and hydrocephalus. Spina bifida is a bifid spine, means those patients, they don't have the bone in here, and the skin is directly on an opened spinal cord. So if you push it, you actually can push to the spinal cord. It's a congenital problem. It can be degeneration like Parkinson and Alzheimer's. It can be tumor, trauma, toxins, and so on. Neurological examination. When they examine somebody neurologically, of course they examine the sensation, they examine the motor command, the behavior, the cognitive function, and that's it for this part.